welcome to Preemie Chats. I had a little technical moment there. A video that I usually play as an introduction didn't play, so thank you for tuning in and welcome to Preemie Chats, a place for parents and healthcare professionals to gather, share stories, and learn from each other. My name is Jenna Morton. I'm one of 3 co-hosts who present this weekly series on behalf of the Canadian Premature Babies Foundation. I'm a career broadcast journalist, mom to 3 NICU grads, including preemie twins who were born at 32 weeks and are now 12 years old. I live and work in Mi'kma'ki, outside of Moncton, New Brunswick. Well, as I mentioned, Preemie Chats is the creation of the Canadian Premature Babies Foundation. The foundation is a parent-led charity that helps families during and after their NICU time through education, support, and advocacy. You can see our website there on the screen, canadianpreemies.org. If you take the time to visit, which I hope you will find all kinds of resources on our website, including links to all of our previous Preemie Chats. We have about 3 years of these presentations that you can go back on all kinds of topics. Today's presentation will be added there when we're finished. There's our parent handbooks, our podcast. Most importantly, though, you're going to find ways to become connected with a community of parents and professionals who are working together to help our children thrive. This is very much a collaborative group. We would love to know where you're coming from, where you're joining us today. Please, in the comments, let us know where you're watching from and what brings you to us. Are you here as a parent, as a grown preemie? Are you in the healthcare profession? We would love to know who's watching, where you're watching from. And as we go through today's discussion and presentation, please feel free to share your stories in the comments, share your questions as well. We will have an opportunity at the end of the presentation to address those. Well, today is May 23rd, which means we are just hours past World Preeclampsia Day. Throughout the month of May, organizations and individuals work to bring awareness to this condition. And preeclampsia is a condition which can happen in any pregnancy, and it may be a contributing factor to an infant being delivered premature. And if you, like me, are someone who was considered at risk or developed preeclampsia, today's presentation is going to be extremely important to you, but it's important for everyone to know more about this condition. So my guest today is going to talk about how an experience with preeclampsia may impact a person throughout their life and highlight what healthcare professionals and researchers are doing to try to help women in the months and even years after they've given birth. My guest today is Dr. Serena Gundy. She's an associate professor in the Departments of Medicine and Obstetrics at McMaster University and director of the Obstetric Medicine Program at Hamilton Health Sciences. Welcome to the Preemie Chats, Dr. Gundy.
Thank you.
Thank you so much for being here with us and tackling this topic. I know it's top of mind for people always in May each year, and it's something that I'm obviously personally very interested to hear more about.
Well, I'm just delighted to be here today. I could talk about this topic till the cows come home, but I will try, as I said, to keep my presentation within 20 to 30 minutes. But for anybody watching or listening, if you have burning questions and even things unrelated but related to preeclampsia that I don't bring up today, feel free to also add those to the comments, because as I said, there's so much to fit in, and happy to tackle any questions you might have from an experience or looking forward that I don't cover as well. So yeah, really looking forward to it.
Fantastic. Well, we'll get right into it. I'll bring up your presentation. I'll leave the screen to you for a little bit, and then I will be back for our question and answers.
Perfect. All right. As our lovely host just introduced better than I could in my opening slide, really what I'm here to talk about today is preeclampsia, and particularly the risk for and an impact on future cardiovascular health. And I'm going to frame this really and this is why I love talking about this, because there are so many opportunities for empowerment and also intervention in the postpartum period. So what I'm going to go through today is a few things. Number one, it's so great. Oftentimes I do these talks and they never align in May. So highlighting the day after now, but really the month, which is World Preeclampsia Awareness Month, and of course yesterday was World Preeclampsia Day. And while I am going to be talking quite a bit about life after preeclampsia and health, I'm also going to do a little bit of an update around what we understand about preeclampsia, because this condition has been happening since, basically since women started having babies, but really our awareness and understanding of what is going on here has made some dramatic leaps, particularly over the last 10 years or so. And we still have so much work to do, but just want to highlight some of the deeper understanding we have. Makes it easier to understand more of it, but also the more we understand, the more we realize, like most things, how complex it is. I'm also going to discuss the links between having had a pregnancy complicated by preeclampsia and particular future cardiovascular risk. I'm going to review the evidence around what we can do to reduce those risks. And I'm also going to identify some gaps in knowledge and care and really highlight what that means, which is there's so much opportunity to improve our knowledge and awareness. And also it allows us to think about what we do know is there are a lot of things we can do, both in terms of intervention, but also empowering people with knowledge. And that's empowering people with lived experience, empowering their families, and also empowering physicians and healthcare providers that look after people who have experienced preeclampsia. I'm just quickly going to do a little explanation about terminology I may use, just to make sure that we're all on the same page. So when I talk about risk factors, a risk factor is something that increases your chance of developing a future disease or condition. It does not mean that you will definitely develop it. A sex-specific risk factor is a risk factor that's specific to one biologic sex because of conditions that are unique to the biology of that group. Like for female sex, we know pregnancy, menopause are sex-specific conditions, and so they deserve their own place in the spotlight. You can also have sex-specific differences within the same, what we used to call traditional risk factors. I don't like that name because that's basically the risk factor of a 65-year-old white male. But that's the labeling in our system. And you can, even with those same traditional risk factors, have sex-specific differences, things like hormone differences or other biological factors. But also really important with all of this to recognize that there are also gender and system-based reasons why there are differences both in identification and in outcomes of the same condition. So before we start diving into preeclampsia, I'm just going to take a step back and frame it under the umbrella of hypertensive disorders of pregnancy, because there's a lot of terminology. And so hypertensive disorders of pregnancy are the umbrella condition of which preeclampsia currently sits. These conditions are very common, and just to give an example, in Canada, they probably affect up to 7 to 10% of all pregnancies, and about 5 to 7% of those are preeclampsia. That works out to about 35,000 affected deliveries per year. And if you think about that's just per year, and then we have in Canada around 7.6 million females that are between the ages of 18 and 44. So that's a lot of people who have been affected over the course of their lifetime that have had these complications. Worldwide, there's about 18 million cases per year, and the rates, really important to know, are increasing of all types. Hypertensive disorders of pregnancy are also a leading cause and lead contributor of something called severe maternal morbidity. And so basically, what that means is you had a complication in your pregnancy during delivery or postpartum where it was a medical complication that impacted you to the point where it impacted your quality of life, it impacted your recovery. It didn't just, it didn't just finish, there were lasting effects. Hypertensive disorders of pregnancy are also a sex-specific cardiovascular risk factor. And why that's important is that cardiovascular disease is actually now the leading cause of premature death in all women. So that's not just people with hypertensive disorders of pregnancy, that's everybody. So this is something where we need to know more and more about what are the specific characteristics and things that are unique to the female sex that might put people more at risk, because this is something that a lot of people will experience later on in life as a complication. So how does preeclampsia fit into this? Because as I said, it's under the umbrella of hypertensive disorders of pregnancy. And there's kind of a simple answer and a complex answer to it. And they're actually both important to know. So if we go really simple, hypertensive disorders of pregnancy basically have three main buckets. So first you have before 20 weeks gestation. If you have any history of pre-existing hypertension, so you had chronic hypertension before you had your pregnancy, or a blood pressure was noted to be elevated, and the diagnosis is always the same in pregnancy. You need basically a reading or two readings taken 15 minutes apart that are over 140 over 90. So that top number, bottom number that you see when you get your blood pressure checked, that happens so often in pregnancy. The reason it happens so often is they are screening for this. And so before 20 weeks, if a blood pressure is found to be elevated, it often gets the label of pre-existing hypertension. The reason for that we'll talk about in a second. After 20 weeks gestation, there are two other conditions, and these are the most common pregnancy-specific conditions, both, again, usually made with the diagnosis of a high blood pressure. Gestational hypertension is when that blood pressure has just been found to be elevated, but it has occurred after 20 weeks gestation without any features of preeclampsia. So it is just the blood pressure being elevated. Preeclampsia is diagnosed as new onset hypertension after that 20 weeks. And in the majority of cases, I do see people every once in a while where it occurs earlier, but on average, it's after 20 weeks. And it has evidence of end organ dysfunction. And I'll explain what that is in a moment as well. That's either diagnosed based on blood work or some of the symptoms that you might have had, at the time the blood pressure was taken. The reason why there's this difference between 20 weeks gestation is that before that, the way that normal blood pressure works in pregnancy, there's a lot of stuff that's happening in the body during a pregnancy. And one of the things is the blood vessels dilate and the blood pressure actually drops a little bit, particularly in the first and early second trimester. The average blood pressure in a pregnant person is only around 115 over 70 to 80. So if you have a blood pressure, at your first visit that's much higher than that, it raises a suspicion that maybe it was elevated before. The other reason is that as we get later on in pregnancy, the blood volume increases and expands in order to prepare yourself for delivery and any risk of hemorrhage. So that's the body's natural way of ensuring that it's safe at the time of delivery to protect against bleeding. And so sometimes what can happen is the blood pressure goes up later on closer to term, and that's gestational hypertension, which if anybody has any questions about at the end, we can talk about a little bit more, some of the reasons why that happens, but I'm going to focus today on preeclampsia. As I said, preeclampsia is new onset hypertension, but evidence of organ dysfunction as well. And there are all sorts of end organ dysfunction, as we call it. That's the official label. And I put this picture up because there's a whole bunch of really weird words on it. But I find so often, especially if you've had a premature delivery, there may have been these words tossed around. So things like HELP syndrome or eclampsia, acute kidney injury, or in fact, we actually look as the placenta as an organ. We look for signs there as well. So you can see things like infarction or abruption. And of course, we look for signs in the baby as well, like being small for gestational age. But really, all of these words are medical terms to kind of describe what is going on with the preeclampsia that causes these symptoms. In most cases, though, it's not the diagnosis is not made with one of these words to start. It's that you've come in with common symptoms like headaches, abdominal pain, chest pain, shortness of breath, just not feeling right in yourself. And those are often confused with really common pregnancy symptoms. So it can be really tricky to figure out what's normal versus what's not, and why it's so important to check the blood pressure, and why you find in your obstetric appointments, people are always checking blood pressure. These symptoms can come on slowly, or they can come on within a few hours. Sometimes you don't feel anything at all, and it's picked up incidentally when the blood pressure is checked or blood work is done, and there's signs that some organs in your body might be affected, or it's picked up when they're monitoring the baby. So lots and lots of different symptoms. It keeps me interested because no one person is exactly the same. So what's the reason for that, though? So what is the difference between preeclampsia and all the other causes of high blood pressure? And what's the reason for all those different symptoms? And really, it comes down to the placenta. Because in preeclampsia, blood pressure is just a symptom of what is going on, another symptom. And that is really being caused by inflammation in the blood vessels. So this is where it gets a little bit complex, but I think it's really important for us to share knowledge. And so sometimes I find I hear from patients, or even I'm guilty of it myself, and I see these things, and we're not actually giving a real explanation of what's going on, or what we understand. So this is about as up to the moment as what we understand is going on to cause all of these symptoms later on in you or baby. And it's a bit of a busy slide because my little magic appear buttons aren't working. So, but I'm going to walk you through it very quickly, and you can look or you can just listen. But this is what we think is going on, and we call it sort of the two-hit hypothesis. There are two stages to this. So the first stage really starts right at the very, very beginning of pregnancy, and that starts with some women have risk factors. And we used to think that the risk factors were all the things that we could see. So risk factors like high blood pressure or diabetes or extremes of age, all these things that we could get from your history. But in fact, it's way more complicated than that. And it's been proven time and again, because we know that only 30% of the time can we actually identify somebody before pregnancy or at the start who we think is at risk of having preeclampsia. So 70% of the time, we didn't have an inkling that this was going to happen, which shows that there's obviously more risk factors and things that are occurring in the body very early on that we have to get better at understanding. And so we now know that there's genetic risk factors, which is why we see it run in families sometimes. And we always ask about first, sisters and mothers. And in fact, even in the dads. So a dad with a mom who had preeclampsia, because of course there's a sharing of genetic information. Things have to partner. And so we know, just like so many things that come from mom and dad, there's a slight increased risk there as well. We know there are environmental factors as well as immunologic ones. And of course, what we call the traditional preeclampsia risk factors, as I talked about, all of those things like high blood pressure, diabetes, autoimmune conditions, those are things that we know affect the tiny blood vessels in the body outside of pregnancy. And so it would make sense, since you have to grow basically an entire organ, as well as growing a baby very, very rapidly. If there are things that affect the very small blood vessels, of course they're going to affect everywhere, and it may be subtle and doesn't have an impact on your day-to-day health. But these little blood vessels that have to grow, and these cells that have to grow, are so precarious at the start and so small and fine that sometimes even something subtly there can have a huge difference later on, a huge impact. And I always think about how amazing it is what a woman's body has to do, and how quickly it has to build all of that, connect a blood supply, start the placenta, start the baby. And I always think back to those images we saw when on COVID with the Chinese hospitals, where they were building around the clock. And I think that's exactly what a woman's body is having to do. So it's there are so many things that have to happen so quickly, and sometimes with that combination of risk factors, or one or other of them, or it can also just be a lightning strike. Sometimes these things happen, and we know in pregnancy there are so many things that have to go on, that some of those cells and the connections with the tiny blood vessels, they don't go perfectly. And so what has to happen is something we call these spiral arteries that have to build and embed. And sometimes when it's not perfect, they can be a little bit rougher and not smooth, on the insides, which is actually really important later on. And so when your baby is the size of I don't know, like a little golf ball, and your placenta is the size of a kumquat, it probably doesn't make very much difference, because there's not a lot of blood flow going back and forth. But as we know, not only does your blood flow get more and everything gets more, but both those things are growing and growing, and the demand on them is higher and higher, even midway through the pregnancy, and certainly by the time the placenta has finished forming around 16 weeks, that there can be kind of tiny little impairments in blood flow, which over time, when the stress is more and more and the work is harder, can start to cause what we call placental ischemia or hypoxia. And that basically means that the connections are not getting as much blood flow back and forth as they need to in certain places, but also that puts stress on those blood vessels, and they can start to secrete inflammation. And there's a whole bunch of different things that are released in the body and come from the blood vessels when that area is inflamed. And the reason I bring that up is because later on in the pregnancy, when if the inflammation gets to the point where it's not just in the placenta, but because it's all your own blood supply, right? It's all your blood going around, that it gets to the point where it leaks out of the placenta, we can now measure some of these things. And so if you've had a pregnancy recently in a place where they can do these tests later on, they can sometimes measure to say, you know what, we see high levels of this inflammation that's being caused by the placenta. And conversely, we can measure something called placental growth factor. And that's sort of the growth factor that's released by a happy placenta to keep those blood vessels nice and smooth. And sometimes we can test, and we notice those things are low in the first trimester, because they're done when they're looking for other common tests and screening. And that can give us an inclination that maybe the placenta might run into trouble later on. But sometimes we don't see any of that, even in people who develop preeclampsia, and it kind of is sneaky and quiet, until that inflammation gets to a point where there's so much of it, and your body is also reacting to it. The immune system is reacting to all this inflammation, that it starts to cause the symptoms either in you, or we see it in the placenta or the baby. And most of the time that happens around after 20 weeks, or sometimes much, much later, depending on how severe the inflammation was to start, and how many of those arteries are good, versus the ones that were impacted. And that the inflammation is what causes the symptoms that you get with preeclampsia. the bottom line, as we know, if the problem is originating and is certainly driven by the placenta, the only way to halt the condition from continuing is to deliver the placenta, because we know it's a progressive condition. That cycle is going to continue until the placenta is removed, and so that's why so often the discussion is around timing of delivery. And it's really a balance when you're an early gestational age, when we're trying to sort of balance between how mom is doing and the symptoms that we might be seeing and how baby's doing. And that's why there are so many different monitoring and delivery experiences. Sometimes the symptoms, I sort of think about it, it's like that's the train. Once the train is on the track, it doesn't get off the track. But sometimes the train is going really fast right from the beginning, and we sort of have to get everybody off, slam on the brakes. And then other times it's kind of chugging along and then it speeds up. And that's one of the areas we're looking into, is how do we predict? Is it going to come fast or is it going to come slow? When is it going to come? And that's, one of the big areas of research right now. After delivery, the inflammation has to wash out of your body. We slam on the brakes, but just like a car or a train, you slam on the brakes and there's still some forward movement. And it takes everybody different amounts of time. And that, again, is why there are so many different recovery experiences and timelines for when whatever you experienced, has finally settled out. And natural physiologic changes that we know, all that extra blood volume that you had by the end of pregnancy, that has to kind of work its way through as well, and that can cause higher blood pressures postpartum, particularly in that end of that first week, and it can make it really rocky over those first particular 2 weeks postpartum, because you're kind of working against the normal physiology of what is happening, and as your body is kind of trying to go back to not being pregnant again. So as I said, I find it so interesting from a medical point of view, because I've seen thousands of patients with preeclampsia, and there's not one single one, even though everybody meets the criteria, everybody's experience is so different, let alone and that's just the medical experience of it. So what are the common features besides, the diagnosis? You had high blood pressure, or you had those findings of, enough of those findings of end organ dysfunction that somebody labeled you as having preeclampsia. The other really common experience is, even if everybody, they say you did as well as possible, everything went as well as possible, it still really is awful to go through. And there are just so many, I can't even do it justice in terms of all the feelings, and it's just absolutely a devastating disease to have and experience, because it's not just you as well, and so many times people feel scared and helpless and confused, and there's so many mixed messages, especially if things aren't happening really quickly. When they're happening slower, you're having to stay in the hospital and you feel like your body is out of your control, and so many medications. It's either lots of waiting or things are suddenly moving, hard to remember things sometimes, and it's really hazy. And of course, with all of this, you're also so worried about your little one or little ones, and that's one of the reasons why we know that emotional and mental health support is so important, both while you're experiencing it and also in your recovery. And the recovery, as you know, doesn't end when baby is taken out safely. What's the other common thing is that every single person I talk to, I haven't found one person who's experienced preeclampsia or these conditions where I haven't just been in awe of how incredible you all are, and how incredible your bodies are, to be able to go through this, and often pushed to the point where we're monitoring, saying, okay, the inflammation has gotten to the point where it's not safe for you to continue the pregnancy, but your body is being pushed to the absolute maximum, or it happens so quickly, and 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 then of course having a premature baby, it suddenly, there's no other time where you'd have a major surgery often, and then kind of have to suddenly switch gears, and you don't have time to recover because you suddenly have been thrust into the completely different world of the NICU, and a totally different language, and all of that. So I'm just always in awe of how amazing people are to get through this, and how amazing women's bodies are to be able to get through this and recover. But I don't mean to sort of, if anybody's thinking, oh my God, you're giving me flashbacks of what I experienced, and I think it's important to kind of go backwards a little bit to try and understand what's happening in preeclampsia, because it's actually really important for what we understand about what's happening later on in life as well, and why there are those links. And as I said at the beginning, as much as there's no silver lining with preeclampsia, but it is an opportunity. It can be seen as an opportunity to really improve your future health, and the health of your families as well. And this is why I love my job, because so much of what I do, I see pregnancy, I see a lot of really healthy pregnancies, and everything goes well. But pregnancy, I see, is also a real window of opportunity, not just with preeclampsia, but other conditions like gestational diabetes, or things that just get brought up to the surface because of all the incredible changes that are going on in your kidneys and your lungs and your heart. Like there's so much going on, and all those organs are sort of pushed to their max, that it can bring things that were previously hidden up to the surface. Or it's just a time where most of us, before we have kids, we don't see doctors very often. And so it's a chance to identify things before complications and problems arise. And those problems might not arise for decades, but if we can find things and identify them at a time where we can actually intervene very simply, that prevents complications happening in our 60s, 70s, and 80s. It's so important. And so that's a lot of what I do is actually focused on the future, not just on the pregnancy itself. And I'm going to come back to this afterwards in another slide. But for me, it's that kind of tip of the iceberg. But I don't want to miss that opportunity, because it'll go back down to the surface, under the surface a lot of the times, after the pregnancy is finished. So I'm going to, as I said, talk a little bit about future conditions that can be associated with having had preeclampsia outside of pregnancy. And the main one that you'll find, and I just did a Google last night, this is from the Preeclampsia Foundation, is of course around the risk of having had preeclampsia and future cardiovascular disease. And here they're saying 2 times the risk of heart disease, 2 times the risk, double your risk of stroke, and it's actually kind of always blows my mind. We know this as a healthcare profession. We've just discovered this in the last really 5 to 10 years. And when I started out, probably getting really interested in this area about 10 years ago, when I was a fellow and still doing my training, I was reading every single paper that was coming out on this, and there were a handful. And in the last 5 years or so, it's at the point where I've stopped reading the papers, because it's over and over again saying the same thing, which is, we know that hypertensive disorders of pregnancy, and particularly preeclampsia, have an increased risk later on in life of heart disease, heart failure, stroke, kidney disease, dementia, all these things. It's been said over and over again. The real question is, what about the middle? Like we've confirmed the link, but how does that risk occur, and what can we do about it? And again, I just want to put it in context that, just like I said, cardiovascular disease is the leading cause of death of women in general. So we know these things are actually, they happen as we get older, heart disease, kidney disease, dementia. But again, I look at this as an opportunity, because if we have something that acts like a little flag earlier on, that gives us decades to intervene. So why should we ignore it? So going back to what the link is, and again, it's complicated, and that's a good thing because it means we're finally starting to investigate women's conditions and sex specific conditions in a way that makes us realize how much work we need to do. But basically, I sort of think about it like a pie. There's different slices, and it may be different, just like with the risk of developing preeclampsia and what happens early on in pregnancy. It might be different for every person, subtly, in terms of what their risks are and what's specific to them. But we know that there's risks, in terms of future health by the pregnancy itself. And then there's also things that happen to the mother's body in reaction to having had the preeclampsia. But we also know that there's things like, we know there's a shared genetic link between hypertensive disorders of pregnancy and cardiovascular disease. We know again that some of the risk factors that predispose to preeclampsia, like diabetes, chronic hypertension, are risk factors for developing cardiovascular disease over time. But coming back to the inflammation, like your body went through all of that. There was all this inflammation, your blood vessels causing them to squeeze, and that blood pressure to go up and sometimes to leak. So you get really, really swollen. It's sort of like going through a fire. You made it through the other side and the fire's out, but sometimes those blood vessels, they're not the same as when they started. So it might get to the point where it recovers enough that the protein is out of your urine, your blood pressure is back to normal, but those blood vessels have been changed, particularly when the preeclampsia is very severe. And we know that as we get older, our blood vessels stiffen naturally. That's the most common cause of developing hypertension. So sometimes these things can kind of pop up sooner. And I wanted to, really kind of nail it down to what's the simple thing. Really, at the end of the day, what we see is that there are higher rates of developing certain, and again, I told you my problem with traditional cardiovascular, but basically the old white man conditions, which we know are no longer the conditions of the old 65-year-old man. They are happening more and more anyways in young women and in women in general, which is chronic hypertension, diabetes, things like high cholesterol. And we see when we compare people who've had preeclampsia, had an experience of preeclampsia versus those who didn't, these things can happen sooner and earlier, than those where the preeclampsia, they didn't have it and it didn't occur. So really, if you can remember one thing from this talk, is that people who have had preeclampsia have about 4 times their baseline risk of developing chronic hypertension. And I say their baseline risk because everybody has different genetics. Everybody has, different stiffness of their arteries, which is, over time will age. So it really depends on what your unique risk is. But on average, whatever your risk was of developing high blood pressure later in life, we know that preeclampsia will increase that risk of it happening, and it will happen earlier and more frequently. And why that's so important is, as best we can tell, undiagnosed and untreated hypertension drives about 80 to 90% of that future increased risk. Because if you think about it, women usually, even if you're in your 40s when you have your first child, most people don't. And if you're in your 20s when you had preeclampsia, that's still decades of time where if the blood pressure settled and you're not having any more babies, everybody ignores you, from a medical side of things, because you're young and healthy and, oh, that was just a complication that can only happen in pregnancy. And even if you're in your mid 40s, the majority of screening now only starts, we only start checking blood pressure, checking things when you're in your 50s and beyond. So those are times where blood pressure can rise up quietly, because it will never happen like what was happening in preeclampsia. This is sort of slow and steady and quiet. And so things can be happening. And if we don't check, we don't know. And that's really the bulk of the way to prevent the complications, because high blood pressure, if it's elevated, there can be medications or other things that you can do to lower that down, and that decreases the risk. I wanted to give you an example though, because we say these things and you're like, well, what does that? Yes, increase rates of blood pressure. But I wanted to show you what this can look like, because it's not just in the decades further. This can be as early as 1 to 5 years after pregnancy. So this was a study that they did, and they looked at 200 people who had severe preeclampsia, so particularly before 34 weeks. And they took these 200 women and they did something called a 24-hour ambulatory blood pressure, which is the gold standard of checking blood pressure. So it's obnoxious. It goes off every 30 minutes, but it really gives us a good idea of the average blood pressure, not just when you're sleeping or, you take it in the Walmart and there's lots of stuff going on, but what's that average? And they found there were 152 patients in their study that their hypertension had resolved, just like the majority of people's does around 4 to 6 weeks or by a couple months postpartum. And the 48 people in the study that still had a diagnosis of hypertension, and that was either because they came into it in pregnancy and then got the preeclampsia, or they were still being followed for postpartum. Of that first group of 152 patients that didn't have a known diagnosis, 41% of them had some form of hypertension, and that was either what we call masked, as in you come into clinic and the blood pressure is fine, but it's actually higher at home, or it's high all the time and it just wasn't recognized. And in those patients where they had a known diagnosis of the hypertension didn't go away after pregnancy, really only about 10 of them were actually optimally controlled. So whatever treatment they were on, it probably wasn't enough. So this is just an example of what this can look like. And again, small group of people, but that's why we focus so much on not just that immediate postpartum period, but really having a good look at the blood pressure, even if things have settled, starting at the 1-year mark. Another example of how people who've had these conditions can kind of diverge as they go forward, even if they haven't had a diagnosis. Their blood pressure is fine at the 1-year mark, fine at the 5-year mark, no problems. This is a group of people where they actually did a comparison. And this was in all hypertensive disorders of pregnancy, so not just preeclampsia. And they compared people that were the same weight, had the same, health, lifestyle, had all the things that were sort of making them similar, except for the fact that they had blood pressure issues in pregnancy. And they actually followed these people along every 3 years, checking their cholesterol, checking blood pressure, checking for diabetes. And what they found is that within the first sort of 5 to 10 years, they could see there was a divergence. And what they saw is that while it's not that everybody at a year or 5 years had the conditions, but their blood pressure was a little bit higher, almost 10 points higher. Their cholesterol levels were a little bit higher. Their sugars were a little bit higher. And so at that time, they might not have needed any treatment, but over time, as we start to develop these higher risk of getting these complications and conditions anyways, these people were developing them sooner and they were being missed. And so an example of that is something that we call in medicine a number needed to screen. So how many people do we have to screen to pick up something? And in blood pressure, for example, in women ages 35 to 40, the number needed to screen in somebody who'd had a hypertensive disorder pregnancy was 1 in 9. So you screen 9 people, you check their blood pressure, you're going to pick up one person who has high blood pressure that you wouldn't expect. Compared to outside of this, where normally, and these are people who had high blood pressure in pregnancy, this 1 in 9, the ones who didn't have high blood pressure in pregnancy, it was closer to 1 in 40. So again, it shows us that the blood pressure is creeping up sooner and earlier in some patients, some people who have had these conditions, and we need to be aware of that, because it's so simple. You just check the blood pressure and you can get a sign that this is occurring. So if you can remember two things from this talk, and I don't know why this is so small, it was supposed to be big, but again, the aside from checking the blood pressure, the reason it's so important is the all of these things that we're seeing, these changes, a lot of this stuff is modifiable, and it's modifiable before all the long-term outcomes occur, before untreated diabetes or undiagnosed hypertension leads to complications in the decades later. And that's why it's so important to be aware. And it comes back again to this window of opportunity, because when you're in your pregnancy, childbearing years, your body is also very, very resilient. And so we talk about it as something called high plasticity, which is there's an ability to adapt and recover in a way that you can't do in the same way when you're in later years. So when you're in your 60s, 70s, 80s. So this is an area where it doesn't take much to make big changes to decrease the risk later on. And so we know that the interventions, and we'll go through them quickly at the end of this, that we're coming to, we know that these simple changes, like compound interest, you do a little bit now and it can have huge impact later on, and we can reduce whatever that risk that was accumulated with having the preeclampsia back to the baseline of what it would have been had you not had that condition, and in a lot of cases actually reduce it further, to end up with people being healthier than had they not had the preeclampsia. So how do we improve health after having preeclampsia? The most important thing is to know your risk. And that, again, is different for every person. We know there's the risk that happens with the preeclampsia itself, but things like family history. So if you have a history, things run in our genetics. If you have a history of high blood pressure, if you have a history of diabetes, if you had gestational diabetes, like sort of knowing what your baseline risk is, if you have any other chronic conditions. And then obviously you need to understand how to lower that risk. And that's, you get the understanding, and then you have to make a plan as to how to move forward. And this is comes from a website that my colleagues in Sunnybrook in Toronto, we spent some time a couple of years ago working with people with lived experience to try and develop something that would give people the information. And ours was a little website, and then Sunnybrook, the Department of Family Medicine and Community Medicine, is working on making this much better, to try and put all these resources at people's fingertips. And also there's the Preeclampsia Foundation, both in Canada and the US, and a lot of other work that's trying to get this information out. But this is just one example of something you can look through to kind of understand what your individual risks are, and pick the things that are right for you. But if I had to kind of narrow it down, if you don't want to do any reading, or you just want to know 5 things to do, the good thing is that these things are good. These things are actually good for future pregnancies. They're good in general. We should all be doing these things anyways, but they're particularly good for people who've had preeclampsia. So if I could distill it down to 5 things, I would say number 1, doesn't matter where you are in your recovery, or you're well recovered and you had preeclampsia 15 years ago, measure your blood pressure, know your blood pressure numbers, know what those levels are, and make sure that it's recorded in whether it's your family doctor, you're going into walk-in, you got a little book, just know your numbers. You don't have to check very often, but if you notice it's high, check it again, and then make a plan for follow-up. Ask your doctor for lab tests to look for high cholesterol or diabetes if you haven't had those done recently. And we know that this is a case where it doesn't matter if you're 25 or 40, we should be checking these, at least at the first year, at the 1-year mark after you've had a pregnancy with preeclampsia. And moving forward, depending on the numbers, at least every few years. And this is different. This is unique to people who've had preeclampsia and other blood pressure issues in pregnancy. Know your family history. So if you have a family history of heart disease or high blood pressure, those are really important things to know because it helps us predict what we might be susceptible to later on. And then, of course, the most important thing that we know has so many benefits for so many things in life, but it's easier said than done sometimes, is move your body. So the goal here for heart health, if you wanted to target, is around 150 minutes of aerobic activity a week. So what that means is just getting your heart rate up to the point where you can still have a conversation, but if you were talking on the phone, somebody would be like, "What are you doing right now?" Sort of that breathing heavy. You can talk, but you would rather not. And so it doesn't matter what it is, whatever you do. It doesn't have to be a fancy gym. If you've got a kid, you've got to wait if they're still not too heavy to pick up. Dance around with them. Like, it doesn't matter as long as you're trying to move your body and nourish your body. And we all know what we should be eating and not eating, but really focusing on small, sustainable changes. And we're really having a big movement in the healthcare profession, as we rightly should, to less so focusing on making it all about weight and body mass index, because we know people can be healthy at any size. And it is so much more important for movement and nourishment, because those things are really what are going to cause, you to be in health long term. And as I normally tell my patients, it's the only time where you get a gold star just for showing up. So simply thinking about one of these things and doing it, but particularly measuring your blood pressure, you don't have to do all of it, but even that one thing of checking your blood pressure and making sure you know your numbers, and talking to your healthcare teams around what to do if the numbers are high, and make a plan for follow-up, because we know that's 80 to 90% of the increased risk long term from that not being recognized. And of course, health is a team effort. And I loved the introduction in terms of the goals of this organization, because we know social connections, community support, these things will improve your health. They really will. And of course, as parents, and particularly as preemie parents, you've been conditioned to put your needs absolutely last. And that goes on and on and on until the kids are out of the house. And those are really, really important decades to try and at least let your health not totally go to the back burner. It goes there somewhere, but sometimes, it's just trying to remember every once in a while to focus on yourself and enlist your partner, your friends, your kids, dog, internet, it doesn't matter. And most importantly, enlist your healthcare providers. And that is really what it comes to sometimes is I talk to people about this all the time, and they say, well, what my healthcare provider, I talk to them, they have absolutely no idea what we're talking about. I'm hesitant to bring this stuff up because they look like me, like I'm nuts, because I'm fine now. That was 10 years ago. And, we know that only 42% of physicians are aware of these lists and risks, excuse me. And obstetricians are actually the most aware at around 50%. And they're not necessarily the ones that are seeing you in long-term follow-up. And this was 2018, and I'm going to tell you, it hasn't changed much. So it is a big thing that we are working on, because we know that if you don't have the engagement and the input from the people that are supposed to be helping you look after your health, it's a lot harder, and we should be doing that. So, why don't doctors and other providers say something? And we've actually looked into this. So really, this is from the mouths of my colleagues and other people, family doctors, midwives, obstetricians. They know that these risks are there, but they're not sure what to say. They don't want to burden people with this information. They think it's not the right time. There's too many other things going on. Not sure if they should talk about it, or should it be somebody else? Or, as we said, 50% of doctors still don't know these things exist. So we have a lot of work to do. We have a lot of work to do in the healthcare community, and we are working on this. We really are, and it's been really great to see a push, particularly with the Heart and Stroke Foundation, and the Canadian Institute for Research, really focusing on female sex-specific medical conditions, and pregnancy is a huge bucket of that. There's been the development of these postpartum cardiovascular prevention clinics, but if you're not in a tertiary center, that's not an equal distribution of healthcare. So we're really trying to work on educating our healthcare providers, and also developing research on how do we intervene early to prevent these complications from happening. And of course, this is all with input from people who've actually lived through this, because we can come up with this great plan, but it has to fit at the right time for in the way that fits the needs of the people who whose health it is. And the one thing I'll leave you with is all of this is sort of culminated. Some of the big feedback we've had from physicians is part of the issue is the way that our guidelines work, our hypertension guidelines, our diabetes guidelines, high cholesterol guidelines. These are all guidelines that doctors follow in Canada. And actually, hypertensive disorders and preeclampsia are in every single one of them, but it's really fragmented. So in fact, you could take all those guidelines together, read through all of them, and come together with a really nice package of, check your blood pressure once a year, check your sugars once a year, check your cholesterol, encourage, activity, but you have to go to 10 different places to get that. And so one of the things that my colleague, Dr. Karen Nuremberg in Calgary, has been working on is she's formed this post-pregnancy clinical network. And in the next year, there will actually be specific best practices that are going to be distributed to Canadian physicians all in one place as to how best to care for people after they've had preeclampsia. And so we're really hoping that this will make a big difference in terms of educating healthcare providers as well. Because you deserve it. And these are just some quotes from when we were developing the website that really struck with me in terms of why why we should be communicating and getting this information later. And I'll just leave it with reading one of them, which is, I had no idea 3 kids later, preeclampsia 3 times, about what the future risks are for me in relation to heart health. And if this is true, I have a right to know so I can do something about it. So I'll leave it there. Thank you so much for listening.
Oh my goodness. Thank you so much for the work that you've been doing and sharing it with us. We've got quite a few questions actually in the comments that have been coming in. So I'm going to pull up a few of them. I don't know if we'll get to every single question that was asked, and perhaps maybe if we don't afterwards, you can take a look in the comments to see if there's others you can address. But there's a few kind of overarching themes I'll try to come up. And one of the questions that I thought was really interesting, Robin was asking about whether the length of time that the mother knows she has preeclampsia, does that have any kind of, correlation with the increase in risks for hypertension and heart disease?
That is a fantastic question, and it is a question that's being asked right now, because we sort of wondered that too. Is like, you have more of that time when, especially when after the diagnosis is made, because we know the preeclampsia probably starts early on, but when that after the diagnosis is made is usually when that inflammation has gotten to the point where it's affecting your blood vessels as well, not just the placenta and the baby. And one of the things that we're looking at is going back exactly and trying to see, does having to sit with all that inflammation versus somebody where it comes on like a 5-car alarm and things get delivered very quickly. So right now we're not sure, but that's actually something that we're thinking about and looking into, and trying to see. And we're actually also looking into, remember how I talked about how there are those markers now in the blood that we can measure, saying happy placenta, not happy placenta. And yes, there's one of these markers of inflammation. There's a lot of other ones as well. And we're looking to see if those levels of inflammation, because not everybody's are the same. And that's the tricky thing too, is that it's not just the amount of inflammation, it's how your own body reacts to it. So some people don't have a lot of inflammation, and I'll use the example of HELLP syndrome actually. So that's a perfect example. People always say like, but I didn't have high blood pressure. Like, how is this weird thing that exists within preeclampsia? And what we think is that in HELLP syndrome in particular, the original thing is exactly the same, the same thing that happens in the placenta. But what drives that specific presentation is that it's the body's immune system kind of overreacting to that inflammation in a way that's getting triggered a whole bunch of things in your own body that we know in other conditions cause a very similar presentation. And so they're actually working on using other medications from outside of pregnancy that are used to shut off that part of the immune system. And there's actually a trial going on right now using that in HELLP syndrome in particular. So it isn't just about the amount of inflammation, it's about how your body reacts to it. And some of that reaction may not cause the same stiffness in the arteries later on. It might, but it causes a whole bunch of other symptoms at the time. So we're trying to tease all this out. Absolutely. So that's a great question.
Yeah, there's so much opportunity, like you keep saying, in the research that's going to be done. Sandy, who in another comment let us know that she was delivered at 29 weeks because her mother was suffering with preeclampsia, asked a few questions, particularly one about aspirin and whether there's any preventative kind of use. I know that's something that people associate a lot with heart issues.
Yeah. So we know that aspirin. Prevents in pregnancy. Very often it's taken either because you have risk factors or there's been something on your first trimester screening that's been shown to be a little flag for future preeclampsia. And we know that aspirin helps those little tiny blood vessels when they're forming in terms of reducing the risk of preeclampsia by about 30 to 40% of that really early onset preeclampsia. So we put people in pregnancy on that to reduce the risk of preeclampsia. The question about long-term, it's a great one. And that's why I love having these chats, because we're actually all asking the same questions, is does aspirin, so for example, taking aspirin even after the pregnancy is finished, does that reduce the risk in your, just like if somebody had a heart attack, they would get put on aspirin to reduce future ones? And that is another great question. And there's studies going on looking at that as well. The problem with all of this is we only started to figure this stuff out about 5 or 10 years ago, really. And in order to follow people for long enough, because although we talk about these risks being doubled, being quadrupled, the overall what we call event rate, which is the number of people who had the condition and have the complication, not only is it still overall quite low, so we would have to get a lot of people enrolled in the study, but a lot of these complications happen decades later. And so we have to then follow those people for all those decades. That's why all the evidence that we have is mostly looking back. So all these studies, the people have had the complication in their 60s, 70s, or whenever it is. And then we look back and we say, oh, they had preeclampsia. So we're looking backwards. Now what the real shift is to looking forwards. But some of that stuff is actually going to take decades to come out, because we have to watch people for decades and wait for them to see if they had the complication more than somebody who didn't take the aspirin. But fantastic question.
Well, and I'll put one more out there to you on that theme of decades and waiting. We have this question about whether or not perimenopause can exacerbate, or how that kind of fits into it all. And I'm very curious about this answer.
We're all living the experience. Yeah, we're all living the experience. So perimenopause, we are still trying to actually define, like, there's the symptoms and then there's some of the findings. And that's something that, as you've noticed, has become a very hot topic in the last little bit, which is wonderful because it's led by advocacy and people finally having the space to talk about these things where it was just ignored before. The one thing we do know, though, is menopause. And of course, perimenopause leads into menopause. So I'm going to clump them in the same bucket. We know that menopause in and of itself, that's a whole nother topic, but that actually, we know that menopause increases cardiovascular risk in certain ways as well. And so there's a lot of research, actually, at the Heart and Stroke Foundation right now, being driven on looking at ways to mitigate that risk, whether it's with hormonal therapies, whether it's with looking at certain things. What is it that after women go through menopause, their risk of having heart disease and stroke and all those things goes up. So I would say it's like, for me, it's like pregnancy and then menopause, and they can be two separate things, but I sort of think about it, it's like this, and then kind of like that, like that again. So again, we are so behind here. We're so behind in this area. So all these questions are fantastic questions, and we know that there are the links. The real thing now is like, what the heck do we do about it? Because people deserve not just hearing this stuff, but they deserve good evidence to say, here's what you do to reduce the risk. So certainly we see there's a heightened peak, an increased risk after you go through menopause. Even if you didn't have high blood pressure issues in your pregnancy.
And I'm just going to leave one final kind of thought with us all, because I think it kind of sums up what you were just saying, that we do need more research. We need more people to want to be followed. And, we did have that question of, how do women take that empowered step themselves to say, hey, I want to help with this information.
Yeah. So in the US, they've done a really good job of this. So the Preeclampsia, and I'll actually reach out to them because they're a wonderful organization, the Preeclampsia Foundation. There's Preeclampsia Foundation in the United States, and there's the Preeclampsia Foundation in Canada. And they've been a really great supporter. I guess they have me, because one of the things I'm really interested in is the mental health aspect that we didn't really talk about. So we're doing all sorts of research into mental health after the first year postpartum. But they have this amazing patient registry. And I think if you're Canadian, you can join into the registry in the US. It's run out of the US, but I think we both have access to that. And this is actually a patient-driven registry where if you had preeclampsia, you can say, you know what, I want to contribute. Like, here's my information. People can contact me if they think they might have a study, or here's my information. People can use it if they think it might be helpful. So off the top of my head, that's the first way. And then we are actually working on developing something here in Canada as well, particularly as it relates to preeclampsia or blood pressure. But that's part of the issue, is there's so many silos. We really have to break those down and work together, because there's always been this idea that, of protection by exclusion in pregnancy and pregnancy research, which is like, oh, they wouldn't want to do that. Like, they wouldn't want to take a medication. You know what I mean? And it's ill-informed, and we're having to break through that. And similarly with women's health research in general. So we are working on that as part of sort of the, clinical network. But I know the Preeclampsia registry is the one where it's very, very robust, and it's patient and person driven.
That's fantastic. I think it's an exciting time in a lot of ways in this field. Like you say, there's a lot of research and a lot of opportunity, and obviously, based on our discussion today in the comments and the activity, a lot of people who want this to succeed. So thank you so much for taking the time to be with us today.
Oh, my pleasure. My pleasure. I mean, like I said, I could talk about this till the cows come home. So, and it's so exciting, and everybody deserves it. So, I would say too, if there's any other questions or anything like that, maybe we can work offline, or I'm available on the internet. You can always email me. It doesn't take too long to find me. So if you've got a burning question, we'll do my very best to answer it, because that's what we have to do. We've got to share the information we have and work together.
That's exactly it. Thank you so much. And thank you who's been watching and asking questions and commenting. It really means the world to know that you're so engaged in these preemie chats. My guest today was Dr. Serena Gundy. She's the associate professor in the Departments of Medicine and Obstetrics at McMaster University and director of the Obstetric Medicine Program at Hamilton Health Services. A reminder that you can find a replay of this on our website afterwards. Our website, of course, CanadianPreemies.org. You can also find information there on how you can help our foundation, our charity that supports the families of premature infants. If you like the work that we're doing, we would love for you to make a donation if you can. And if you can't give a financial donation, just sharing and telling people about what we're doing makes all the difference. We want people to have access to this information. We also will be here again next Friday, every Friday at 1 p.m. Eastern. We do preemie chats here online. I hope that you can join for next week's discussion as well. And until then, take care.